and welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories, but keep it edgy yet light-hearted.
Podcasts share their desert island drugs and joyful patient stories.
Welcome, this is the Oral Apothecary Podcast. My name is Jamie Hayes. Coming up in this week's episode, which is episode 7 of our second series, we're joined by Fiona Penniston-Bird. Fiona is a nurse and non-medical prescriber. We'll hear from Fiona in a moment as she shares her desert island drug, a career anthem, and recommends a book for the Oral Apothecary Library. Our micro-discussion this week will look at what does it take to be a good prescriber and what are the competencies involved. After last week's afternoon slot, we're back in our usual evening slot with a beer and a glass of wine. Before we go any further, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Welcome both.
Oh, where do you going, James? All right, Gimmo? How's you doing, all right? This is this week's podcast. If you love Gavin and Stacey, you must listen to Bryden and Ruth Jones. It is very, very funny.
Unlike that impression.
Yeah, exactly.
Did you have enough feedback after the Friends impression?
No, we did. But you knew who I was, didn't you?
Yeah.
Anyway, on a more serious note, you know how we are building the Oral Apothecary Spotify library? I was thinking, I know we set things up when we were a little bit bored during COVID, but it struck me as I was cycling home tonight. I listened to a track that has been played a lot recently myself, and I wanted to put it forward as a possible anthem in relation to the Oral Apothecary during these COVID times, because if you've not heard it, it's by James, who've been around for a long time. It's called All the Colours of You, and it's written about COVID and how we're stuck in this cave, and I just think it's a proper anthem. So my suggestion was, could we have it as an anthem or not?
We can do what we like.
We can have it up there. There's a story behind it.
Yeah, no, it's really good actually. If you like laid and sit down, you'll love this stuff. It's really good.
Controversial, but we'll go with it.
You sent it as homework and it's a good song. And just to make you jealous, Steve, one of my first gigs back is going to be James and Happy Mondays on the same bill. No. That's happening in November. I think it might be my first one back.
Oh, wow. Oh, so you'll definitely allow me to have that then, seeing as we've already talked about the Happy Mondays in pills, spills and
bellyaches.
That's it. Okay, yeah, that was just my little bit this week.
Did I tell you my story the time I met Bez?
Yeah, I think we've had that on.
Gimmo, what you been up to?
Well, first of all, thank you very much, Steve, for the mug. The picture's on Twitter, but Steve very kindly sent me and Jamie Oral Apothecary mug as part of our field testing of future merchandise. But it's a very nice gift and appreciated. So this week I was at the IHI conference, so the Institute for Healthcare Improvement conference, which was good. Like all these virtual conferences, it was good but a bit rubbish in that, you know, the virtual experience is just lacking, isn't it, at the end of the day? But there were some really interesting people in there. One of the talks was about Safety 2 from a guy called Geoffrey Braithwaite, who's a big name in this field in Australia. I think we've talked about, or we've mentioned Safety 2 in passing in the podcast.
Yeah, appreciative inquiry, isn't it?
Well, it's the idea that traditional models of safety are all about errors and looking at what goes wrong. And those solutions tend to involve things like adding in barriers, checklists, you know, the Swiss cheese model, that sort of stuff. Where Safety 2 is a focus on what goes right. So if you think about it, errors account for between 1 and 10% of all activity, if that. So what happens in the other 90% of times that things go well? How do we learn from that? So it's not easy, but it's a really interesting concept, I think. And I actually came across an example of it this week. So you've heard of DateX. Well, someone I was talking to was introducing a system called GreatX. And basically what they're doing is they're encouraging people to report and feedback on good days and when things go really well, so that the teams can get together and learn from what happened when they had a good day or when things went well, as opposed to just a bad day. And I just really like that idea.
Just for jargon monoxide purposes, DateX is a system for reporting incidents, isn't it? Things that didn't go well.
Yeah. So Safety 2, I think that's one for us to discuss for the future. If anyone is interested in it, just Google Safety 2 white paper and you get a really good document on it.
Hang on, did you not get Jeremy Braithwaite on for us?
I tried.
Do you want me to tart myself on Twitter again?
There's no need. I've published a book chapter with him.
Ah, right. Okay. Get on with it then, James. Get him on.
You're welcome. Okay, I've taken some bookings for face-to-face workshops and some team coaching sessions, so that's good. Things are starting to move in the right direction. I've noticed that we've started to have a Delia effect aren't we, with our book recommendations. After, it's Oral Apothecary Book Club is starting to shift some gear, and so we're seeing that on Twitter. And then I just wanted to give a shout out. Look, the NICE Shared Decision Making Guidance is out today, Thursday, and there's an e-learning package to go alongside it with modules covering cognitive psychology, evidence-based medicine, probability and certainty. Sounding good, isn't it? Consultation skills, and staying up and getting up to date with your knowledge, your information mastery, really. So all topics of interest to the three apothecaries I know, and to you, our listeners, I'm sure too. Okay, my great pleasure to welcome Fiona Penniston-Bird to the Oral Apothecary podcast. As I mentioned, Fiona's a nurse and non-medical prescriber. She works in an independent role advising health providers on the development and implementation of non-medical prescribing. Fiona is prescribing lead for nurses at Medway School of Pharmacy at the University of Kent and the University of Greenwich. She's also a support tutor at the University of Nottingham. She's a member of the BNF Nurse Prescribers Advisory Group and is also a member of the editorial board for the Journal of Prescribing Practice. Welcome, Fiona, to the Oral Apothecary podcast. What are you up to at the moment?
Well, thank you for having me. It's nice to be here. At the moment, I have loads of essays to mark. So we have an exam board on Monday, up to my neck in legislative essays and supporting students through the prescribing programme in a world of MS Teams and trying to overcome the fact that, things freeze and I can't hear people and, all those things that we're having to deal with. But also, alongside that, I deliver CPD for non-medical prescribers on a national basis and have been doing that for a number of years. So I am very keen that registered prescribers keep themselves up to date and are aware of their accountability and responsibilities in prescribing. So busy.
Very good. Can I set the context for this? Look, I've read a letter out every week for the last couple of things, and so this is this week's letter. 2006 in the British Journal of General Practice. Should nurses prescribe? Patricia Hewitt's announcement that doctors' unique privilege to prescribe from the entire formulary will be in future usurped by nurses and pharmacists subject to checks on professional competence have understandably raised the hackles of doctors who see this as yet another attack on their professional status. There can be no dispute that nurses can prescribe some antibiotics, many simple analgesics, and all dressings and lotions. Indeed, most doctors would instantly and willingly transfer tomorrow the prescribing of grocery lists for celiac disease, a patently inappropriate duty for the hard-pressed doctor. But to make the entire British National Formulary available to clinicians not trained in diagnosis, let alone therapeutics, is a potential disaster for the safety of patients and for the financial integrity of a health service constantly calling for more scarce resources. The 4 health ministers of the UK have a statutory duty under the NHS Acts to provide medical services to their populations. This duty cannot legitimately be fulfilled by the provision of alternative professionals, and certainly not by nurses acting as quasi-doctors working to protocols, let alone by pharmacists with no pretensions to diagnostic skill. British GPs practice to the highest standards in the developed world. They are economic with medicines, they are trained in diagnosis and spend years honing their consulting skills. Every member of the public is statutorily entitled to those services. I thought I just set the tone with that 2006.
I remember that as well.
I remember that in 2006 because at the time I was working with Strategic Health Authority developing non-medical prescribing across, rather large region. I mean, all these years later, we can look back on that and I think we can say we were successful. An economic evaluation written in 2015 shows that there, at that time, were over 80,000 non-medical prescribers. My guess, although there hasn't been a review of that economic evaluation, is that there could be maybe 120, 150,000 now. And back then, in 2015, it showed a saving of £777 million, saving the NHS that figure. Goodness knows what the number is now.
If I'm a patient listening to this, I don't quite fancy a non-medical prescriber. Just let our audience know what we're talking about.
Just before we go there, now, being academic, we like to give credit where credit's due and we like to reference where our information came from. I also am a firm believer in discredit where discredit is due. So please, can you tell us who wrote that letter?
I'm deliberately not saying who wrote the letter, and I was withholding his name from our podcast.
Well, we shall perhaps put it in the show notes because, I think history is an important subject, isn't it? And who knows, that person might have completely changed their view anyway. So it was historical. So I just wanted to ask for that.
Yeah, it's an essay, not a letter as well. So it could be a commissioned piece. It could be, be devil's advocate, couldn't it?
Carry on. Sorry, Fiona. Do you want to answer the question?
So non-medical prescribers are healthcare professionals who have undertaken a regulated programme of study, and the courses are regulated by the professional organisations, the professional bodies, the Nursing Midwifery Council, the GPHC, the General Pharmaceutical Council, and the Health and Care Professions Council, to make sure that we provide robust standardised training for those students who learn to be prescribers. Actually, doctors don't do this programme of study. So in order to be a prescriber, your qualification has to be registered, recorded onto the professional register. And if you don't meet the standard required, you don't pass the course. So that's what a non-medical prescriber is.
And that letter, Jamie, when was it written?
2006. And so that's just
So that was when independent prescribing came in. But before that, we had, and I'm trying to remember the terminology, supplementary, that was it. Yeah, supplementary prescribing. And that was
2006. Sorry.
Okay.
Sorry, I was going to say 2006 was a very big year for nurses and pharmacists because it opened up the whole BNF for nurses and pharmacists who have done that programme of study to be able to prescribe from the formulary. Now, of course, they wouldn't prescribe from the whole formulary. No doctor does that. They define their scope of practice. So during the training programme, we help students to give their scope of practice a bit of a shape. So for some, that's fairly clear. If you're working in the area of diabetes, then, it's got a very particular shape. If you're working in general practice, then sometimes that's a bit harder to define. But it's important that non-medical prescribers are aware of what their scope of practice is and that they stick within that. And that continues through their prescribing career. And a way of helping them do that is using the RPS competency framework.
And we're going to pick that up in a minute in relation to our micro discussion, so that's fine. And for the record, I also became an independent prescriber in the big year you're talking about, 2006.
Whoa, lovely. Where did you do it?
At Chester University. And then I did the conversion from supplementary to independent at UCLan, which is University of Central Lancashire. I failed the conversion first time. I had to resit it.
Well, supplementary prescribing is, mind you, the conversion was independent, wasn't it? But supplementary prescribing is, I've never been the biggest fan of it, to be honest with you. And it's kind of what I call leftovers. So I think, it's a good thing that you did the independent side of things. Most people, given the choice, don't use supplementary prescribing. It is what I call, don't quote me, leftovers.
Fiona, so I've run lots of sessions from when supplementary prescribing started. We were involved with the mentorship programme, and I've run numerous sessions over the years to the people qualifying as prescribers. And when I ask them why are they in the room, there's a real mix of, most of it is for personal development and, seeing an opportunity and wanting to become a prescriber, which is great. And when I ask them, when they qualify and they go back to the system, I ask them, is the system ready for you? And is the system, are you going to slot it back into the system? And the response to that is always very disappointing.
Okay, well, it'd be interesting to know where they're working because virtually I would say probably every NHS trust, it has many non-medical prescribers. So they should have system processes in place to enable those individuals to get going with their prescribing. But what I think is lacking is the CPD for prescribers. And I'm surprised after all these years that it still seems to be an issue. I'm amazed that. Sorry, Paul.
So I was going to say, I wonder if what Jamie's might have been hearing as well is, in my experience, it was those sort of pharmacists and nurses who were working in primary care where that issue was, Jamie. I don't know if that was the issue, because I certainly know a lot of pharmacists in community pharmacy got their prescribing qualifications and then very frustrated that they were never using it. That's changing in Wales a bit now. And I think it was the same in the early days of pharmacists in primary care, is people weren't quite sure how to use them in the best way, but that's obviously evolved now into the sort of stuff you're doing, Steve.
It was the same in secondary care. I managed lots of people and I used to say to them the importance of doing it, and then people would do it and then they wouldn't use it, and I used to get so frustrated. Whereas now I think we're in a world, Fiona, aren't we, where, look, there's so much request and so much need for different types of prescribers in the NHS that if you've done it, managers want to put you into a place where you can use it because they need you.
Yes, and it's normally identified before you apply that it's needed in that particular service. I think for community pharmacists, it's very difficult to implement prescribing because, number one, who's going to pay for the prescribing? How do they get access to an FP10 budget? How do they record their prescribing? How do they inform other members of their healthcare team of any prescribing they've done? And who pays for it? So if it's private prescribing, then it might work. So for example, travel clinic, that sort of area. But if you think you're going to be privately prescribing for a diabetic patient, you've got it all wrong. It's just not going to happen. So in community pharmacy, it doesn't fit so well. But pharmacists working